All right, so first of all, who are we? So my name is Kate. I work for Healthinsight. We're a nonprofit organization that works to improve health and healthcare. We operate in 4 states in the Western United States: Oregon, Utah, Nevada, and New Mexico. One of our initiatives is to help providers care for older adults, specifically around screening for depression and alcohol misuse. This initiative is one of ours to help look at different approaches to increase these screening rates. And so it was really fortuitous that we were connected locally to behavioral health leaders who have such an interest in this topic as well. As we understand, billing and coding for these services is a key part of increasing these screening rates and overall taking good care of people. Our contact information is available at the end. We can provide individual assistance to clinics who want to learn more about this for Medicare. So if that's you and you think we might be able to help you, please be in touch because we would love to be able to do that. A quick disclaimer, this information is through the very, very hard work of some wonderful people that you're going to meet today. It was created by the Integrated Primary Care Leadership Collaborative, which is a self-convened group. They got themselves together because they think this issue is so important. They're primary care behavioral health leaders in Oregon who have a mission to support clinicians and leaders in primary care practices in advancing integrated care. And to that end, we have relied on the expertise of billing and coding experts and behavioral health providers. But this information is provided as is. We've done a ton of work to vet it and to make sure that it's as accurate as possible. But this is an evolving topic. And so we are presenting this info to you as is, and we have done all we can to verify its accuracy, but please make sure that you're verifying information with the health plans, the coordinated care organizations, and other payers that you might work with. There's a lot of information that we want to cover today and some great presenters, and I'm going to introduce them in a minute, but I want to say first something about the technology. We expect just a large number of questions, and we already have 225 people who've joined us today, and we may have more, so you are all on mute, so we don't have to worry about hearing your whole music or your dog bark. But we do want to hear from you, so there's a chat box that I mentioned already before. Please type your questions into that. We've tried to save a lot of time at the end to answer those questions, and we'll get to as many of them as we can, but we expect to get a lot of questions. And so if we aren't able to follow up, know that we're going to take all of that and see what we can do for future sort of educational presentations to get at what we know people are really asking us about. I'll share contact information too, so that you can get in touch with us if you have some really specific follow-up pieces. So we'd love to know who's here. So if you could, and this is also your orientation to the chat box. So if you could find that chat box and type in where you are and what your position is in your organization. Are you a behavioral health provider? Are you a biller, medical assistant? Are you an office manager? Something totally different. Would love to start seeing some of those chats come in so we know who is here with us today. And so you know who else is listening in. While we hear from all of you, I'm going to go ahead and introduce our presenters today. So first, we welcome Dr. Joan Fleischman, who completed graduate training at Pacific University's School of Professional Psychology and a fellowship in primary care psychology at the University of Massachusetts. She's the Behavioral Health Clinical and Research Director for OHSU's Department of Family Medicine, leading the expansion of their behavioral health services across 6 primary care clinics. She's worked closely with other clinical leaders on strategy planning, program development, training of clinicians, and workflow implementation. She's focused her work on practice transformation, population reach, alternative payment methodology, and team-based care. And she's currently involved in projects in a program evaluation of primary care-based medication-assisted treatment program and an implementation study of screening approach to intimate partner violence in primary care and implementing trauma-informed care standards in a family practice clinic. So very busy. We're glad to have her here. And we also have Dr. Julie Oimaja, who began her career in primary care in 2004 in a federally qualified health center in Portland, Oregon. It was her experience there that really inspired her to go where the people are and serve them there. And so her passion is for supporting primary care patients, staff, and clinicians, and that's really fueled her work as a clinician leader in 2 primary care organizations in Oregon. Her passion is to promote a new kind of primary care, one that's empowered by psychological science and practice. This results in sort of an advanced primary care with intentional staffing for addressing the biopsychosocial needs of all patients who are served. While her current focus is on primary care, her professional experience in psychology comes from a really diverse background, from residential care for patients with substance use concerns to community mental health to private practice to hospitals. She's served and supported in a variety of patients and clinical teams. She's currently an adjunct professor at George Fox and provides consulting and technical assistance to primary care clinics and healthcare organizations as a member of Mountain View Consulting Group. These are impressive people, so I'm going to take a breath there, if you don't mind. We also have two billing and coding experts here with us today. Our first is Jonique Dietzen. She's a certified professional coder and project manager from Multnomah County Health Department. She's a college graduate with a Bachelor's of Science in Finance and Associates in Science and Math. She has 7 years of experience working with commercial health insurance payers and an additional 4 years of experience in medical office as a revenue cycle manager and project manager. She's been a certified coder since 2014, worked at Multnomah County for the past 3 years, and that's given her the opportunity to improve billing and reimbursement for the integrated behavioral health program there, working closely with providers to identify billing codes to improve fee-for-service reimbursement. Denise Phillips is the revenue cycle manager for OHSU Family Medicine, 7 years experience working in medical offices as a biller and an additional 3 as a revenue cycle manager. As in that role, she's had the opportunity to work with her fellow presenter, Dr. Fleischman, and implement billing and coding reimbursement for their team of behavioral health clinicians. And without further ado, I'm going to turn the webinar over to Dr. Julie Oimaja to get us started.
Well, thank you so much, Kate, for that lovely introduction. I'm just so happy to be here and talking about this issue. So what are we talking about today? Well, I thought we would start by talking about who we're talking about today. We're talking about behavioral health clinicians and behavioral health clinicians, psychologists, LCSWs who are working in primary care. And more specifically than that, we're talking about behavioral health clinicians working in primary care in the primary care behavioral health model. I'm not going to spend too much time talking about the primary care behavioral health model today, but I did want to refer you to a special edition of the Journal of Clinical Psychology in Medical Settings that is coming out, that is goes through lots of nice literature on this new model, the PCBH model, from the research in terms of its practice, how it works, what's the definition. It's a really great resource. But I wanted to start us there because we're talking about behavioral health clinicians who are working within this model in primary care teams for the goal of supporting the biopsychosocial needs of around 3,000 to 6,000 patients generally. And their goal is to enhance the whole care of that population. This unique way in which they're practicing has some complications in terms of being able to be paid for the services that they're delivering. I would explain they have very specific billing and coding challenges, the BHCs who are working in this model. I explained the billing and coding challenges in 2 ways. The first way is that these behavioral health clinicians are working in primary care. And primary care is a system that is not set up for the delivery of behavioral health services. From check-in to receiving payment for billing, all operations in primary care are set to support primary care practices. And so the first level of complication for BHCs that are practicing in the primary care behavioral health model is that they're working in primary care, a system that's not set up to bill for their services. The second level of complication in BHCs working in this model of practice is that they are doing a work that is a little bit different than mental health practice historically. So mental health practice historically has been really a practice that takes care of around 60 to 70 patients at a time, where a therapist will work with the patient weekly, bi-weekly for months or years, take care of about 60 to 70 cases at a time. The behavioral health clinician is doing something very, very different in primary care. Their goal is not necessarily just to take care of 60 to 70 patients at a time. Their goal is to take care of 3,000 to 6,000 patients at a time in teamwork with their primary care clinicians, their RNs, their MAs that are all working together to promote the biopsychosocial health of many patients. So the complications in getting paid in terms of billing and coding, I think, are one, because they're working in a context that's not set up for behavioral health services, and two, the behavioral health services that they're delivering are a little bit different than the behavioral health services that are generally delivered. And speaking to that, so mental health services, as I described historically and traditionally, the billing and codes that are set up to support those services are set up with those specialty mental health services in mind, and not the services that the BHC in primary care delivers. So some ways in which these BHCs are different is their goal is to take care of the biopsychosocial health of all patients, but also, looks like I'm having difficulty advancing. They're doing things like having their schedule be 25 to 50% of the day being available for same-day access. This is very different than specialty mental health or the traditional practice. The work that they're doing is focused. They're doing focused clinical assessment and intervention for many patients, and if identification of more severe concerns or facilitating patients to the specialty programs. They may be identifying patients with for higher level needs, like patients with a certain level A1C for diabetes, and putting them on a registry to manage more rigorously. And their work is, because they're in these primary care teams and they're working with their PCPs and other team members to take care of a subset of patients, they start to rework all primary care workflows. So the BHC skills need to be used within the team. So things like, if you're doing universal screening, one could start to rework that universal depression screening workflow with the BHC to identify anybody who's positive for depression screening could, within 30 minutes, because of the same day access that a behavioral health clinician is allowing in this model, could come in within 30 minutes of being a positive screening in the clinic and do a more thorough assessment and developing a more thorough care plan with the BHC skills. So these folks are also helping rework all these primary care workflows to take care of these 3,000 to 6,000 patients. So the billing and coding challenges from my perspective is our challenges are that we're in a place where operations are not created for us, and two, the way in which we're delivering behavioral health services is just so different than what we have been historically trained to do. We do have some good news to share in Oregon, actually several bits of good news. One is that the primary care behavioral health model as a part of the patient-centered medical home is being widely adopted in Oregon. Many practices in Oregon are adopting this BHC as a part of a primary care team to take care of a subset of patients. In addition to that, because of all the adoption of this practice in Oregon, the BHC leaders that are implementing this work on the ground are really active in convening each other to identify standard practices that could be implemented across organizations. And actually this tool that we're going to talk about today is the product of a self-convening, as Kate mentioned, of a group of BHC leaders who are implementing in organizations with multi-clinics, coming together and identifying that one of the top issues that they wanted to work on was helping BHCs be able to bill and code in the current system. Other things that are happening is that BHCs and in primary care are actually defined in our Oregon law now because of convening of BHC leaders and primary care leaders in our state. This definition with all these different folks who are licensed practitioners has been put into our state law and is what we consider in our state as BHCs in primary care. We're not going to talk a whole lot about why we need BHCs in primary care. We've been around long enough where, you know, in a situation where primary care has 70% of all primary care office visits are driven by psychosocial variables. The need for support of behavioral health support in primary care is well understood. And so we're not going to talk too much about why BHCs are in primary care or why they're needed, which is a great thing to be able to say now that I've been in this work for some time, that we're really past this step. We're really into the step of, okay, that we know we need BHCs in primary care working to take care of the whole health of patients. We're past that to how do we do this? And even past the implementation, because folks have been implementing this BHC model for some time in Oregon, even knowing that the payment for this model is a little bit shaky. So we know we're doing the right thing when we implement things and we don't know if we're going to get paid for it. But we're well past the why BHCs are needed in primary care teams. and well into the how, and particularly the how in regards to getting paid. Now, this slide is demonstrating something that I know is probably not too unfamiliar to this group. You know, behavioral health practitioners and primary care practitioners, they have been trained in different places, they have practiced in different places, and even who pays them are different people. There's a pot of money for physical health services that's paid by certain parts of insurance, and then there is a mental health and substance abuse pot of money that's maybe paid by a completely different insurance altogether. Which just models the historical siloing of our training and in of our practice. But as integration has been understood as something we need to move towards and away from this siloing, perhaps at some point integration, and in some places this is happening, integration of these pots of money may be what happened. But at this point in time, there's still a pot of money for physical health, a pot of money for mental health and substance use, and different insurers with different expectations for this money. So that is where we are, which is another complication because the primary care context is used to billing to the physical health plan. And now we have behavioral health practitioners who most of their codes or many of their codes for the services they would deliver in primary care would need to go to mental health plans. So those are some of the problems that we have in terms of being BHCs as a part of primary care. Primary care context and also the services we're delivering are so very different. So we have many operations and implementation challenges, but when we pulled folks together, because we realized we needed to pull together in Oregon with the leaders who are implementing this work and doing it together because there's so many challenges. When we pulled together, we asked this group, this integrated primary care leadership collaborative, what are the top issues that we should work on to standardize this work together? And I'm sure it doesn't come as very much surprise that the top issue was billing and coding, getting paid in the current situation with the current billing codes that are available. And like I mentioned before, those codes, of course, were created in a system in which behavioral health and primary care practitioners were trained in different places, practiced in different places, and paid by different people. So the code set that is developed for mental health specialty practice and not this particular practice in mind. So, but saying all that, we have our code set that's available, and luckily there are some codes changing that are very helpful for BHCs and primary care teams, particularly the collaborative care management codes. There is some movement in that direction, but we do have a current CPT code set, and BHCs do provide services that meet those billing codes. So the work of our IPCLC, and here's a group of us here, it's not all of us, but a good amount of us in our last meeting. Let's figure out what these codes are that we can bill and develop a tool for BHCs to help them provide the service, document the service, and build the right codes for the services as they stand now. There's lots of good things happening in terms of alternate payment methodology and value-based care and these kinds of things, which will help the BHC innovation in primary care. But while we wait for all those things to happen, there are billing codes that BHCs can use. And so our first work with this group of leaders on the ground was to create a tool to ensure that the BHCs in our practices were able to document their work appropriately and bill for the codes that are available. And so I'm going to give it over to Joan now, and we'll go ahead and pull up the actual billing and coding tool that we created with this group of leaders.
So this is available, and Healthinsight just sent out the link on our chat, but I just wanted to introduce and orient you to this tool that we created really for our systems that we wanted to really share with everyone, because we think it is translatable and can be more generalizable than our systems that we've used it in. So here you can see that we've broken it up into different code sets. These are the preventative medicine counseling codes. And again, they're by time, and then there's the group ones. You can see the health and behavior codes here. And again, there are the initial assessment and then the intervention, reassessment. You can see the group codes there. The smoking and tobacco counseling codes are here. And if you see, we have The description of the service, or the name of the code, the longer name in the code, the description of the service, and then what we have identified as to be required in the documentation, and then some tips and guidelines. So those are really to help clinicians figure out which code, and if there are anything that's really not in the required documentation or the description that we have found helpful in guiding our clinicians in the use of these codes. So just to keep going, we have our alcohol and substance use services, and then the new BH care management that became available in January of 2018, as well as the screening, so both developmental screening and brief emotional and behavioral screening for children. And then we have our mental health codes that are the Diagnostic Evaluation and the Psychotherapy codes. So that's essentially what our tool goes over, and some psychological testing. We know this isn't happening everywhere, but it does occasionally take place in primary care, and then some group psychotherapy as well. So, and at the bottom, at the bottom there are several paragraphs that that coincide with the asterisks that are kind of notes for what the yes and the no in the different columns means for the Medicare. Yeah. So it's really important to actually read through those because they really help explain some of the points. There's a question on the chat around if this is going to be sent out. It's available online right now with a link, and that link was about 4 posts back on the chat sent by Health Insight.
And we'll also email it out to the folks on today along with a link to a recording for the presentation.
Thanks. So I don't think I have control to continue to advance the slides. So,
Kate, if you can give me control. There we are. Oh,
great. So, I think one of the things that's really important for us to think about is just the different ways that we have supported BHCs in the past. Fee for service, this is kind of the idea of billing for a service and receiving payment for that specific service. There have been alternative payment methodologies and models that have been rolled out, the per member per month payment that different states and different CCOs have rolled out. And really this is, when we're looking at the ideal model, we're talking about one BHC FTE for every 6 FTE of primary care clinician. And we're looking at a BHC population penetration of about 20% for the primary care practice that is touching or having contact with 20% of the primary care practice. Those are the benchmarks that are that CCOs that we've worked with have chosen to reimburse at a higher rate for a PMPM model. And then previously this work really had been supported by grants. There's still grants going on, opportunities for grants, but that seems to be kind of changing to the PMPM model. So really, I wanted to really hit home on the benefits of billing for behavioral health clinicians' work. I think it's important to capture the services that we're actually providing. There's no other way. I mean, we have all found different ways to count what we're doing or kind of contextualize what we're doing, but this really, really hits home in terms of counting what we're doing. So I think that there have been practices, and there may still be many practices that are kind of piggybacking on primary care clinician visits, where they're using incident twos or the primary care clinician upcodes their visit. And what we found is that really this hides the work that we're doing. It doesn't make it visible. This is a way for us to really have visibility. And kind of downplays that we're independently licensed practitioners who can do this work and have CPT codes that we can bill that can capture the specific and valuable work that we're doing. It also helps us, just to promote the primary care bottom line. And I think in general, really show the value of our work.
So this is just one example of an insurance company and how these codes might break down in terms of how the insurance company would pay for it. So for the example of Medicare, Medicare credentials psychologists and LCSWs. Medicare will reimburse for psychologists and LCSWs who are credentialed for mental health services. Although Medicare credentials licensed clinical social workers, in terms of the health and behavior service codes, they will, even though LCSWs are credentialed with them, they will pay for psychologists to do these codes. And in terms of the preventative medicine codes that are listed, Medicare won't pay for psychologists or LCSWs who may be providing services that are reflective of those codes.
Okay, so how to succeed in the short term. So when you look at which BHCs you have, you need to also look at what your insurers pay the most. For us, it's psychologists and LCSWs. We also have CSWAs working with us and students, which don't typically get reimbursed. And then also do your research and talk to your payers. Find out who your top payers are, talk to your provider representatives, figure out what types of services your BHCs are doing, so you know which code sets to use and talk to them about. And when it's also important to get BH and your billing and coding team together and train them together, so that way questions that your BH staff may ask, billing can answer and vice versa, and really learn this process together and how to use these codes. And we also engaged our clinic and senior leadership to let them know what the benefit was in using these codes and billing for BH services. And then we also do billing and coding audits just to make sure that we are performing the services that we're billing and documenting correctly, and that we're getting reimbursed for them. And now we will move on to our billing code options.
I just wanted to address some of the questions that are coming in. Some of them are very specific in the chat, and we may not get to your specific questions on today before the Q&A section, but we'll try to get to them in the Q&A section. And also, some of them we'll be addressing as we go along, so just hold tight. We have a lot of information to share with you.
So the first set of codes that we'll go over is the health and behavior codes, which are the 96150 to 96154, which are individual, and there's a couple for group health and behavior. So these are for the prevention, treatments, or management of physical health and medical problems. You have to perform an assessment and some sort of treatment. And then it addresses the psychological, behavioral, emotional, cognitive, and social factors of the physical health and medical problem. These are not for assessing and treating for mental health disorders. You can have a mental health disorder diagnosis, but it really needs to be listed as secondary and not the primary code on the claim. And for these codes, you do report them 1 unit for each 15 minutes spent, so time does need to be documented.
So for each code set that we talk about, we will give an example of a clinical situation that would match that code set that a BHC might support. So here we are, we have Jane, she's 32 years old and she's pregnant. She received a diagnosis of gestational diabetes and she's concerned about her health and the health of her baby. She was referred to the behavioral health clinician to support with these concerns and to help her engage in a physical activity plan and a diet plan that will help to decrease this gestational diabetes concern. The interventions that a psychologist or an LCSW would perform in this kind of case would often be motivational enhancement, identifying the pros and cons for Jane and making the changes. And then doing some self-monitoring, just monitoring the food intake in a diary, and behavioral activation, just getting up and doing pleasant things, achievement-oriented things, just getting activated. So these are all psychological interventions that could be applied to this situation of a person with additional diabetes concern. So linking the medical condition that was referred and diagnosed by a medical provider, and then linking that with the interventions, really focusing interventions to help improve the gestational diabetes. And that's what health and behavior are for.
All right, and so the next set of codes are 99406, 99407. These are the codes used to report tobacco cessation counseling. So these codes can be used anytime the provider counsels the patient on steps to stop using tobacco and tobacco products. This can include a discussion, discover the specific barriers to quitting, or a discussion of practical methods for coping with those barriers. The provider may end up writing a prescription to help the patient quit, or may refer the patient to a support group if needed. These are time-based codes, and so the amount of time spent counseling the patient on tobacco cessation would need to be documented. But the good news is it's as little as 3 minutes. So if at least 3 minutes is spent counseling the patient in tobacco cessation, 99406 can be reported, and then 99407 requires at least 10 minutes of tobacco cessation counseling. Medicare will cover 2 cessation attempts per year, and each attempt may include up to a maximum of 4 intermediate or intensive sessions. So that means that Medicare will cover up to a maximum of these codes a maximum of 8 times per year. Just as a side note, taking a look at the diagnosis codes, Medicare does not consider tobacco use a covered diagnosis, but rather the patient must be diagnosed with use, abuse, or dependence of nicotine, or a history of nicotine dependence. And so when choosing the diagnosis, you don't want to just indicate that the patient is using tobacco, but rather they have a dependence or use, abuse of nicotine. And the FDA does consider vape products to be considered tobacco products. So if the patient is working on stopping vaping as well as smoking tobacco, these codes can be used.
So this is the example for our tobacco and smoking cessation counseling. Jorge is 37 years old. He's quitting smoking and he's having a really hard time stopping. And he has been he's being seen by the BHC and really focusing on tobacco cessation. And just talking a little bit about kind of cravings and triggers and validating his experience of how challenging this is, and then kind of doing some motivational interviewing around going back to the PCP to consider the different options for nicotine replacement. And we would use tobacco use disorder for the diagnosis.
Right, the next set of codes, 99408 to 99409, are for alcohol and substance use screening. And so it's actually alcohol or substance use or abuse structured screening with a brief intervention service. So at SBIRT for short. Usually, they must use a valid screening instrument, so typically an audit or DAST screening is completed. The brief screening involves an intervention and same-day session for the intervention of the alcohol or substance use. At least 15 minutes needs to be documented, is spent with the patient in order to bill for the first code. So if it's brief and less than 15 minutes is spent, then you can't use these codes. But the first code is used for at least 15 minutes of intervention with the documented structured screening results, and then 99409, second code, is used for at least 30 minutes spent with the patient.
So our example of the screening brief intervention and referral is we have Jorge again, who screened positive on an audit when seeing his primary care clinician for nicotine replacement options. Luckily, there was a BHC in clinic, and the BHC holds same-day appointments, so was able to review the alcohol use on the audit with Jorge in a timely fashion on the same day. The visit focus for something like this that would work for these billing codes would be, education on where his alcohol use places him in comparison to other people who drink. The interventions would again be motivational enhancement would be used. Support that, this is it's challenging to make changes. It's challenging when one has been drinking for some time, and to make a change in this area, as well as any kind of behavior change, really, supportive and empathic support for that. And if the issue was of a significance of a diagnosis for alcohol, a referral to a chemical dependency program. And what's really nice about having BHCs as a part of primary care is that BHCs really know the mental health and substance abuse programs in the community. They understand the services in great detail, and so they provide great value in the primary care team to understand the specialty services when they're needed, and also to fully facilitate a patient from the primary care level service to the specialty mental health or addiction service, and check in on that. So those would be the kinds of interventions a BHC would do, and very helpful for patients in primary care. The visit diagnosis tied to this intervention would be alcohol use disorder.
Okay, so 99484 is the Behavioral Health Care Management Code. This does need to be provided face-to-face, and it's to do initial assessment or follow-up monitoring, and including any use of ethical validated rating scales. It's to plan behavioral health care planning in relation to behavioral and psychiatric health problems, which includes revision of your care plan, because maybe patients aren't progressing or whose status have changed. You can also use it to facilitate and coordinate treatment if they need psychotherapy, pharmacotherapy, counseling, or psychiatric consultation. And it's used for continuity care with a designated member of the care team. So it can be behavioral health with the PCP as well. And it does need to be at least 20 minutes per calendar month. So what we do is we just leave the encounter open for the month until we reach that 20-minute mark, and then we close it and bill it out.
So I just wanted to address a question on the chat. So all of the codes that we're presenting right now are billed to the physical health plan. If a payer has separated mental health billing or benefits from physical health benefits, then all these codes would be billed to the physical health side of that plan. And we'll denote when we are talking about codes that could be billed to a mental health side if the plan is split up. So John is actually a patient of mine. He's 65. He comes in once a month for a check-in. We're not really doing therapy. We're not really doing prevention services. We're not really doing health and behavior. It's really about care management. And what we do is we kind of just go, he's really involved with lots of different agencies. ADS is involved in his services. He has he has Meals on Wheels. He just has a lot of different people who are helping care for him. And so what we do is just kind of go over how are things going. We talk about his meds because he has cognitive impairment and memory is really hard. We talk about upcoming appointments and making sure he has like plans for transportation. And we're really kind of talking about any other changes that might be happening. And it's a supportive visit, but it's also kind of a care coordination service. And we do use major depressive disorder as the diagnosis because that's really what is impairing his functioning and why he has all these services.
So for the developmental screening code 96110, it's for developmental screening for developmental milestones, speech, language delay, and it's scoring with documentation per a standardized instrument. The provider uses a standardized form to analyze the presence of any developmental disorders using measurable parameters. These are things like the ASQ, the MCHAT, the Behavioral Health Assessment Scale for Children, and you see in the slide all the ones that apply to it. Usually these are screenings done during infancy or adolescence to screen for any delays. And then the provider may use the form to determine whether the patient requires any additional workup for the developmental disorder. The provider can use various standardized screening instruments, and as long as they score and document, they can fill this code.
There's several questions on the chat coming up about the additional collaborative care codes. So my understanding is those codes, we talked about the care management code. The additional codes, my understanding is that they're for psychiatric services, and our talk today is really specifically about the codes that psychologists, LCSWs, non-medication, non-medical provider, behavioral health clinicians can bill for. That's our focus today. But yes, there are some great codes that have come in to support collaborative care models with psychiatrists in addition to the care management code. But of that set, the care management code is helpful to the work of LCSWs and psychologists working on the psychosocial aspects of health as a part of primary care.
And all of the codes that we are talking about today are anybody who is to bill to Oregon Medicaid, anybody who is listed in our slide about Senate Bill 832 and who is considered a BH clinician or BH provider. So you can reference that slide when we send them out. So this is just an example of maybe what you'd use the developmental screening code for. Rose, she's 3, she came in BHC same day, she came to see BHC, same day visit. We talked with her, we interviewed her mom, and we reviewed the ASQ and the MCHAT, and we discussed what the developmental milestones that we'd expect for Rose would be, and then we reviewed the concerns we had, and we talked with mom a little bit about her concerns as well, and we talked with the primary care clinician about referring, and mom about referring the patient to an early intervention program.
All right, the next code is for brief emotional and behavioral assessment with scoring and documentation per a standardized instrument. And so this can be billed out whenever the provider administers a test to evaluate the patient for an emotional and or behavioral problem. And this includes various standardized instruments such as depression inventory, ADHD disorder scales, or symptom questionnaires. The documentation should include the test score and the results. And you can actually report this code multiple times, 96127. It can be reported for each instrument that's used for assessing the emotional state and behavioral of the patient.
So example of brief emotional behavioral health assessment by a BHC would be an example would be Charlie, who's 15 years old, and luckily his BHC can see him same day because they save same day appointment slots, seen same day, and luckily so because Charlie just came in for a well adolescent exam, and as a part of that exam endorsed suicidal ideation, which is something we want to take care of right away and very well. So BHC, of course, a psychologist or an LCSW is well equipped to review suicidal ideation with the teen and develop, review the risk, develop a safety plan to meet that risk. So it would be something like reviewing the patient health questionnaire A, the suicidal ideation question, and then going further and using a robust risk assessment process to determine the level of risk for Charlie. And then once determined the level of risk, moving on to what kind of safety plan could be put in place to mitigate that risk to allow for continued being in the community, or if not, what kind of inpatient services might be necessary. A formal diagnosis may or may not be made in a situation like this. And if so, if a formal diagnosis is not made in this situation, using this code and reviewing these screeners and then looking at it more deeply, the visit diagnosis that would work for the situation could be something like suicidal ideation.
All right, so the next set of codes are specific for preventive medicine for the state of Oregon. Oregon Medicaid has expanded coverage to allow psychologists and LCSWs to bill for preventive medicine. Currently, Medicare and most commercial insurance carriers will deny these codes, indicating that they are not billable services by LCSWs. And so if you're unable to bill these codes in your area, or you mainly bill Medicare or commercial insurance and you encounter problems, you can always consider billing these services as Incident 2 and submit the charges under the name of a supervising physician or provider. That's about all I'll say to billing Incident 2, because that in and of itself would be an entire different presentation. All right, so Oregon Medicaid allows BHPs to bill for the preventive Medicare HCPCS codes, and therefore has extended coverage to allow them to bill these preventive medicine codes as well. They are classified as evaluation and management services, but they don't require a physical exam. Instead, these codes are used when the visit is focused on counseling to prevent illness or injury, promoting health, or counseling to support a wide variety of symptoms. So we will use these codes when the focus of the counseling is not for a specific diagnosed medical condition, but rather the counseling is to prevent a condition or the recurrence or worsening of an existing condition. And so this can include various mental health conditions or substance use, behavioral problems. It could be nutrition or diet and exercise counseling, or counseling on social issues, including like STI prevention or family problems.
So this is just an example, a pediatric example of a preventive medicine counseling visit. Jill, 7, she comes in. Her mom actually brings her in because mom is really concerned about some of her anxiety at home and some school avoidance that's been happening lately. She's missed a bunch of school. So what we've done is really spent some time talking with Jill, talking with mom. We drew some pictures with Jill just to get a sense of where she's at, what her thoughts are around school and what's going on at school. Used some psychoed for mom and Jill about anxiety, talked them a little bit about what anxiety is, and explored what Jill is actually kind of worried about. We used school avoidance, anxiety, and worry. All of those would have been appropriate code to use for preventive medicine counseling for this visit with Jill.
I've just been following some of the chats. There's so much expertise coming in through the chats about different challenges with the different codes that we're talking about. We definitely don't have all the answers, but we've been working on this and have found some success in billing. But I just wanted to say that one of the most successful things that we did was having people like me and Joan, clinician types, teaming up with our billing experts like Denise and Jonique. We really need to work closely with each other, because this is, as clinicians, you know, we try our best to understand all this code stuff, but we really need our billing experts to help us. We really know what the clinical problems are, how to assess clinical problems, how to treat clinical problems, and we know what we document for those things, and our billing and coding people help us find the codes that match the documentation and service that we just delivered. So I found so much, it's just so relieving to have the support of these billing experts. We really a team approach to this effort, and then coming cross organizations, multiple organizations in this integrated primary care leadership collaborative who are trying these things out, piloting them, teaming the leaders of the BHCs leaders, teaming up with their billing leaders, and then multiple organizations doing this. We're going to find out a lot together, and I think that this webinar today, there's people all across the country who are listening to this webinar. There's a lot of good that can come out of this. Clearly, this billing and coding thing is challenging for BHCs and primary care. And there's a lot of, how many people? Over 300 people signed up for this webinar. So there's a lot of will to solve these issues. And we're just here today to present the problems that we have encountered and some of the solutions that we have, and solicit a conversation to keep this momentum going, so that we make sure to support BHCs in primary care, because they're doing such amazing work. So now we're moving into the mental health codes. What we just talked about before were all codes that are technically physical health codes that bill, if the services are separated and mental health is carved out, they bill to the physical health plan. These codes are the traditional codes that us psychologists and LCSWs are very used to using, but our primary care colleagues and our primary care contacts may not be familiar with these codes, and there may be great challenges to bill out for these codes by these practitioners who really do know these codes and these services well. But these services are delivered every day by BHCs in primary care. The problem is not the service delivery. The problem is getting paid for the services delivered in this for various different reasons.
All right, so the first psychiatric code that we're going to talk about is 90791. This is used for psychiatric diagnostic evaluation. So in this service, the provider performs a psychiatric evaluation of the patient with the aim of making a diagnosis. Documentation should include a collection of information about the present and past behavioral concerns, as well as a past family, medical, and social history. And it should include all diagnostic tests that were performed to work up the diagnosis. This code applies to new patients or any patient that's undergoing a re-evaluation.
So an example of a diagnostic evaluation that would be done by a behavioral health clinician in primary care. Here's Jane again. She's had her baby. Luckily, she was able to come to see the BHC for the gestational diabetes, and that was helpful. And she's come back of her own will because she realizes that perhaps something that the BHC said in regards to the gestational diabetes maybe hit a little bit on anxiety that Jane was also having. And some marijuana use. And Jane, as many good moms, it's a good moment of life change where people are really invested in making changes for their own health, but for their children's health as well. And this is the case for Jane. She, of her own accord, now that she has a relationship with the BHC, came in and said, "Hey, I have this anxiety, and it's I need to deal with it. And also, I've been using marijuana fairly consistently as a way to try to manage this anxiety." She filled out the PHQ-9 and the GAD-7, which is the practice of the BHC to take these measures at regular basis to measure the outcome of the interventions that the BHC would do and to track it in the medical record for everyone to see objective outcomes over time in terms of the BHC supports. And the GAD-7 did indicate some anxiety that needed further assessment. So further assessment was conducted, including a history of present illness of the anxiety and of the marijuana use. A risk assessment was done in regards to an elevation on the suicide ideation question. Observations of the patient occurred, differential diagnostic process, considering, is this a history of trauma? What was the history of this present illness? Is there other reasons? What is the diagnosis of anxiety for this particular case? A differential process occurred and was documented, and a diagnostic formulation was arrived at, which included that generalized anxiety disorder was the best fit for what's been going on with Jane, as well as this cannabis use that is in attempts to manage a long-term experience of generalized anxiety disorder. And perhaps the BHC, being generalized anxiety, may start off with a course of 4 visits perhaps of anxiety management training, teaching Jane about anxiety and this disorder, and teaching some coping skills that may be very helpful for her. So that might be the place that a BHC might start. But the work of that visit was a diagnostic work that came to a diagnosis, and it's appropriately documented, and the code would work.
So the next code is psychotherapy, which is probably the most common that everyone is more familiar with. You have your individual psychotherapy codes within this code set. There's also family with or without the patient present psychotherapy and group psychotherapy and multifamily group psychotherapy. So for these codes, it's insight-oriented, behavior modifying and/or supportive, face-to-face with the patient, family, group. And documentation should highlight the therapeutic communication, attempts to alleviate the emotional disturbances, change maladaptive patterns of behavior, encourage personality growth and development. Time does need to be documented for these. For the lowest code, the 90832, it's a minimum of 30 minutes.
So an example of this is Jane. Jane comes back. We're talking a lot about Jane today. Comes back to talk about her anxiety and how she's going to cut back on her marijuana use. So really, this is a psychotherapy visit. We're doing psychoeducation. We're exploring motivation. We're talking about what skills and coping she has now. How do we build upon those skills? Maybe even talking a little bit about where her anxiety comes from, how long she's had it, when it started, when she started using cannabis, and we'd probably review some of the physiology around anxiety, how marijuana impacts emotions and mood, and probably maybe even do some mindfulness training with Jane. So I think that generalized anxiety disorder, cannabis use disorder as secondary would be appropriate diagnoses for these visits. And these are diagnoses, the psychiatric Diagnostic Evaluation, that and these psychotherapy codes are being used by, how do I say this? We're as mental health clinicians, we are making the diagnosis often. And sometimes they already have the diagnosis or the PCP has made the diagnosis.
Okay, and then there is psychotherapy for crisis, which is 90839 to 90840. For these codes, a crisis state is defined as a life-threatening or complex state requiring immediate attention to a patient in high distress. The provider primarily aims the treatment at mobilization of resources to diffuse the crisis and restore safety to the patient to minimize the potential for psychological trauma. To use 90839, it needs to be, the treatment session typically lasts anywhere between 30 to 74 minutes, and then you bill 90840 each additional 30 minutes that you spend with the patient beyond 60.
There's lots of good questions coming in about psychotherapy and some of these mental health codes. The way in which, so you hear us, the billing folks talk about what the CPT requires to be documented, to be delivered in the service. And so what we are looking at is CPT guidelines and what they say psychotherapy is and what it needs to look like in the documentation in order to attach these particular billing codes. So our reference is the CPT and what they think is required in order to use any particular code. I hope that answers some of the questions that have been coming through. In regards to a case that might work for psychotherapy for crisis, we have Felicity, who's a 25-year-old transgender patient, presenting in the lobby, stating she's feeling suicidal. BHCs in primary care typically, for the purposes of serving a great amount of patients, deploy population-based approaches like focused assessment and focused intervention. But certainly longer visits do occur, and they occur based on the clinical need of the patient, and this might be a really good example of that. Patient in high distress, and a lot of work needing to be done to establish the risk and to establish a safety planning that would mitigate that risk, hopefully to keep Felicity in the lowest level of care, but if not, escalating to a care that would keep Felicity safe in this period of distress. So Most of the time, the visits are 15 to 30 minutes in length. For a BHC, it's a population-based approach to try to take care of many patients, identify patients for more significant longer-term services, and facilitating patients to those services, so to keep the door open for new patients. But like this example brings about, this fits psychotherapy for crisis, and the clinician would, of course, do what is clinically necessary for the patient in front of them first. So the intervention might be some grounding, some identification of and connecting to natural supports to de-escalate this current crisis, safety planning, of course, and a rigorous follow-up scheduled for a situation like this. The visit diagnosis may be something like suicidal ideation. Perhaps there would be something in this visit in relation to gender dysphoria, but those might be potential visit diagnosis, and the work would be to take care of the suicidal ideation and keep Felicity safe.
And then psychological testing, the 96101 code, is billed per hour of a psychologist or physician's time. That's both face-to-face time administering tests to the patient and time interpreting the test results and preparing the report. This is not a code that LCSWs can bill. It's for psychologists and physicians only. And within this code, you would evaluate an individual's mental functioning in terms of intelligence, cognition, personality, emotional quotient, and behavioral traits. The test scores are measured against a norm, which is a standard average score of the general population. These tests could include personality tests, attitude tests, IQ tests, achievements, and direct observation tests. And they use various stimuli, including verbal, visual, written, and computer media.
An example of psychological testing that may be done by a psychologist who's working as a behavioral health clinician. I've definitely seen the use of tools like the repeatable battery of neuropsychological status for concerns around dementia. This is an example of a patient who is 28 and the PCP is wondering if the psychologist behavioral health clinician could do a neuropsychological screening to identify a current neuropsychological functioning in the context of Jackie just had a car accident a couple of weeks ago and had some symptoms of concussion and PCP diagnosed concussion. Patient didn't recall the crash. My report and looking in the record, that seems to be substantiated in the ER, kind of coming to within at the emergency room. So significant impact. So having these concerns, and the PCPs knows that the psychologists can do some neuropsychological testing and have asked for some testing of functioning, of which the BHC has provided that testing, and also done a clinical interview, looking at the medical record, looking at what happened here, the past functioning, premorbid functioning of Jackie. And after looking at these various things, after a couple of weeks after a car accident and some testing seemed to be within normal range and consistent with background history. So that might be really helpful in the care for this patient and information for the PCP. But the psychologist might suggest further testing in the future, but this might be a use of when psychological testing in primary care may be useful. And the diagnosis would be made by the physician, which is a medical diagnosis of concussion, and the testing would be of functional status at the current time. So we're moving into some tips for success. Joan, are you reviewing this one?
No.
Okay. All right. So provide the service that is requested and clinically indicated. So as a BHC, many issues come in for us to assess and treat. The most important thing to take away from a conversation about billing and coding as a clinician is that we just provide what's necessary. We get a referral for a particular problem, and we're going to assess that appropriately based on our clinical backgrounds and experience, and we're going to provide the appropriate, make the appropriate evidence-based recommendations. We provide the service first, that's appropriate to the clinical need based on our training. And then there are these codes that may be usable, that may match that clinical service. So first, as a clinician, provide the service that is necessary, and then be knowledgeable about the billing codes and see what billing code matches the service that you provided. This is, as you can see, it's fairly complicated for BHCs in primary care. There are codes, which is good to know, but there's many codes, and how to apply them to any particular clinical service, that takes a little bit of effort. Hoping that today gives some tools to support that work, the tool in and of itself, and then these talking through cases that match the different kinds of codes. But you want to do the service first, and then find the code that matches it. Another point is that BHCs in primary care provide diagnostic evaluation and psychotherapy. There's a lot of talk about the primary care behavioral health model being focused assessment and focused intervention, and it certainly is. Having same-day access and doing visits that are 15 to 30 minutes, and this is definitely what occurs in this model. But in that context, there are many times in which the service that we are delivering looks a lot like diagnostic assessment. Actually, I would say a lot of what primary care providers want from me as a psychologist is say, what's the diagnosis here? Because I might have medications, or we might suggest treatments that may be helpful. Could you make that diagnosis? And I would like to be able to say, yes, I'm a psychologist, I'm trained to diagnose. So we do this work. And then, when it comes to psychotherapy outcomes, in our first 4 psychotherapy visits, people have the most outcome that they are going to obtain. And most people, don't stay for years of counseling. They come for 1 to 4 visits, and they get what they need, and they may come back. And that's a capacity that the BHC does have to provide brief, focused assessment and intervention. And then if things are good and progress is going all right, then providing an open door for future care if necessary. And if things are not getting better, facilitating that patient to more comprehensive treatments that may be helpful. So we definitely, we're LC Studies as psychologists. We have skills in assessment and treatment of mental health concerns, and we provide these services within this setting on a daily basis. All right. And also, just to note, there is a psychotherapy for 30-minute code, so that is there. And so, in our CPT code set, there is allowance for a 30-minute psychotherapy code. That's been there before BHCs were around. So there is an understanding the psychotherapy could occur in 30 minutes because actually there's been a code there for some time for that purpose, even before BHCs.
Julie, we're just running a little bit behind schedule, and I think maybe for the next couple slides, if we could just talk through what we were thinking about, and perhaps just kind of go through them very quickly, if you don't. Is that okay?
Yeah, absolutely. So we had planned a talking through of a case that may have many suggested billing pathways. Maybe this could just be a take-home for folks to think about all the different ways in which one could bill for the service. Would that work?
I think really our point for the next 2 slides, this one, and we also have a pediatric example, is that for both of these visits, you could, depending on the focus of the visit and what actually happens in the session with the patient, you could bill it a lot of different ways. And that was really the take-home, is that both these patients have a lot going on, and depending on what you actually did and the intervention that you did, it might be billed different. You might use a different diagnosis and a different billing code. And this is just to illustrate that this is complex, and it takes clinical acumen, and it takes BHCs who are using their clinical judgment around what needs to be addressed in that day's visit, what was addressed, and then what were they treating, what visit diagnosis are they going to use, and then what is the billing code that coincides with that. So enough.
Excellent. Really good cases to review afterwards and see how you might select some of these billing codes.
And if you have follow-up questions after the webinar, you can email Health Insight, and we're going to kind of figure out how we can answer some of your questions. So we've asked both Jonique and Denise to kind of just go through these questions and maybe quickly answer. And you guys have a lot of questions. The audience has a lot of questions about this information. So I'm going to let Jonique and Denise take it away.
Right. I currently work for an FQHC, and so for us, it was mainly a matter of figuring out a way to capture the services that are being provided so that we can report it as part of our FQHC and indicate that we should get paid for these extra services. We didn't necessarily do any additional communication with payers. Denise, you deal with a little bit more on the commercial side.
Yes, so within OHSU Family Medicine, we have your regular practices at FQHC and an RHC, and so before we started billing for behavioral health services, we talked to our top commercial payers and Medicaid, and then some of our Med Advantage plans as well, just to kind of give them different scenarios and different codes that we would potentially be billing to see how it would affect patients, whether or not our warm handoffs would create an additional copay for the patient if we billed for those, or how they would really start us billing these services. So provider reps for different companies became my best friend in figuring out the different scenarios and how we would handle them. And I know I saw it on the chat about warm handoffs and the separate copay. That does happen, but we made it very clear with patients when we do the warm handoff that it is a separate visit, and our behavioral health clinicians do have a script that they follow, just so patients are aware that we are billing and there may be some out-of-pocket involved. And then we also talk to our senior leadership, practice managers, just to make sure and get everyone on board with what we were doing.
Great, thanks, Denise. I want to talk about some specific challenges. Some of your audience, some of the questions are asking about these challenges. These were challenges that we faced in our department. Denise and I have been working through the problems. One of the things we noticed, and this happened right in January, that patients at the beginning of the year had large deductibles. If they had separate plans, mental health and physical health, they had possibly 2 deductibles. And some people who didn't have separate plans, they just have a large deductible for their entire physical health plan or their entire health plan. So we learned the hard way, and so next year I think we will be talking with patients at the end of the year, probably starting in October, talking with patients about, we're nearing the end of the year. You probably want to check what your deductible is, and be knowledgeable about your plan so you're not surprised if you get a bill. So we had some patients who got really, really big bills, and that was really just because their deductible wasn't met because it was January. Another thing that has happened is we've had patients who cannot afford their copay. They have a high copay, or really any copay would be a financial burden. So our system has allowed us we work in a very large system, and the system had already in place a payment plan for what the patient owes. Also, our system has a discount program depending on their where they fall with the federal poverty level. Again, we work in a very large system, but these might be. Can you go back to the other slide, or is that your way of telling me to hurry up? No. Oh, okay. So I just wanted to. So if the patient can't afford the copay, you may think about implementing a discount program depending on their income, or implementing a payment plan for patients. We also have trainees in our practices, and we're not billing for trainee services at this time. And so that's another option for a lower cost service. Another thing that's happened, we've had patients who are very, very concerned. They receive a notice from their primary payer that the services will not be covered and they will be receiving out-of-pocket costs. So that, but they have a secondary payer, and the secondary payer will be covering the service, but they're not aware of that. So it's, again, really helpful to encourage your patient to understand what their primary payer and secondary payer cover, and then also to understand that sometimes they get an explanation of benefits that have numbers attached to it, but that's not a bill. And so patients often need a lot of education. So lessons learned. So consider who you have in your clinic. When you're hiring, you really want to consider who your payer mix is, and who will be able to bill. We in our system have decided to hire LCSWs and clinical psychologists because we know that is who we can, who Medicare pays for these services for. So that's, we've made a decision to hire those two credentials. We know that is a luxury. We're in a large metro area with a large number of licensed clinical psychologists and LCSWs. So we know that's not always an option for rural clinics or clinics that don't have a large workforce to choose from. Really consider your payer mix. At our system, we have many clinics, and each payer mix is a little bit different. Some of our clinics have mostly Medicare patients. Some of our clinics have mostly commercial payers. Some of our clinics have mostly Oregon Medicaid. So also consider your payer mix. We as a department really went back to what are our core values, and we went back to that we provide services regardless of ability to pay, and we will work with patients on an individual basis if this becomes a barrier to care. We started with just billing 2 BHCs in 2 different clinics that had very different payer mixes to just see how this would affect our patients. And we learned from that. We learned that we didn't actually have that many problems, and we also learned that what the problems were. And Julie, do you want to speak to the last point?
It was so helpful when BHC, when, getting to know Joan and some of our integrated primary care leadership collaborative colleagues coming together saying, hey, we need support, let's all get together. It was lovely that one of our very innovative payers in our area decided to provide neutral facilitation for this group of BHC leaders that are getting this work done on the ground and supporting BHCs and practices. There's real power across the board in terms of the difficulties with implementing behavioral health practice in primary care, bringing together BHC leaders and their supporters. There are many people that are championing and cheering us on and want us to be successful, BHC leaders and BHCs. And building a collaborative, if you're in a state that doesn't have this pulling together, I could not recommend it more, to be with folks who know the difficulties, the challenges of trying to implement this work in this new context. And there's so much vision and so much goodwill towards this work. There are just some challenges to overcome, and it's so much easier to do that with being closely connected with wonderful people who are doing this work. So we started with billing because that's often what is most concerning to folks, but there are many things that we will be working on in terms of standardizing this work for the benefit of patients across organizations within our state.
So
Hi, everybody. Hi, this is Kate again. I'm going to kind of go through some wrap-up pieces, but also we could do a couple questions. I am going in no order, but again, the benefit of using the chat was we captured all of those, and we knew that this content was going to be way more than we could cover in this time. So we'll do follow-up and to let you know how we might be able to get at some of those specific questions. But one that really stood out was, you mentioned this partnership between billers and coders and behavioral health providers, but how are they getting their competency and knowledge in these areas? And what suggestions, maybe Junique and Denise, would you have about how billers and coders can get this education?
Well, I think it really starts with just reading the code books, and the codes are there. It's just they're not used as frequently. So if the coding and billing team just take the time to really familiarize themselves with the different codes, they can then take the information back to the providers. And I know someone in chat had mentioned, doing provider audits. And I think it starts with just being really familiar with what the billing options are, which was the point of this, is to let you know that we've got lots of different codes that could be billing options, and then just taking a look at the services provided and matching them up with the best billing code, and hopefully being able to get reimbursed for those services.
Great. Denise, would you add anything to that?
No, I think she put it great.
Awesome. So one other question that was just more general and stood out to me is some primary care practices are just reluctant to bill for behavioral health codes if not all insurances allow billing for the same services. And we've seen very clearly today that it's just more complex than that. So what recommendations would you have for primary care practices that are reluctant to bill under our current circumstances?
Well, I could say that was us. That we were real concerned about, oh gosh, Medicare doesn't pay for this and Medicaid doesn't pay for this. And what we actually sat down with our CFO and Denise, and we said, what's our goal here? And I think our biggest goal was to capture what we're doing. I think it's really a philosophical way of thinking about implementing billing, is that you're gonna bill for the services you're providing. And the clinician will do what is in their scope and bill the correct code for the service that's provided that's clinically indicated. And then from there, you can look at, okay, who are the payers that pay which codes? And that's why I really suggest a pilot with one behavioral health provider, just to see who is paying what. And what Denise did, and she can speak to this, she actually called up our payers that we work with frequently and talked with them. Out of these codes, what do you pay? Who can bill these codes? And we collaborated with our payers. We've had Oregon Medicaid, our CCOs, come into our clinics and observe the work we're doing to understand. Our colleague Brian Sandoval at Yakima Valley's Farm Workers Clinic will always tell people, invite your payers into your clinic to see the work you're doing. It's very powerful. So I totally understand the reluctance. I totally get it. I think it's important to understand what your payers reimburse and understand who your payer mix is, and then to set up systems, and maybe Denise could speak to the systems that we have set up where the patients are not being hit with large bills if a payer does not pay that code. So for example, if we bill commercial insurance, Denise, preventative medicine counseling visit, and they don't reimburse preventative medicine counseling codes, what happens with that charge?
We end up writing the charge off just because they'll deny it as no authorization, can't bill the patient, provider responsibility, or just this provider credential can't bill this code, and we know we can't bill the patient at that point. And so it's just, for us, it's just really that simple, is that we have, if it's a true denial, we don't bill the patient for it.
And that's a system we've set up.
Yeah. Denise, could you, this is kind of related to another question. Are some or many commercial insurers in Oregon adopting these codes? We've kind of talked about it briefly, but can you just talk about what your experience has been with that?
So for the preventative counseling codes, it seems to be about a 50-50 split with our commercial payers, that some will pay for them and some follow Medicare guidelines and they'll deny them. For the health and behavior ones that are also typically the physical health, it's about the same.
Great, thank you. That's really helpful. So we can do another question, but I'm gonna move forward and just say a couple of things first, and then maybe we'll do one last question. So you can find the coding and guidelines document. The links have been put in the chat. Here's a link again. Again, we're gonna send out a recording of this presentation, slides, and a link to this document. So anyone who is registered for the email will get that, and you should forward that to colleagues who might want this information. We've captured all the questions in the chat today. We have them, we know who you are, and if we can do specific follow-up, we will. If not, this was very helpful to let us know how to structure for future learning opportunities around this. So please keep them coming. You can continue even after today by emailing orbh@healthinsight.org and getting in touch with us. And again, Health Insight's work is really around Medicare. And so for those of you who had Medicare specific questions in the chat, we will follow up with you individually and share what we know and let you know where you can get more resources on that for that in particular. So maybe you've talked about this a lot, but maybe we could just finish on, there are lots of comments about getting denials for lots of reasons. And can you just talk about how you've talked about it a little, but say more about how you've pursued the process of looking at what gets denied and incorporating that into your workflow?
Janique and Denise, could you?
Yeah, so for us, when we receive denials, especially surrounding the health and behavioral codes, because the health and behavioral codes require that the focus be on a physical health condition, not necessarily a mental health condition. So a lot of it is then going back and taking a look at the chart to see if it supports a rebill using a more physical health diagnosis rather than mental health. And coding is all about making sure that the code matches the services provided. And so it's not always necessarily about changing the code just so that we can get paid, but rather making sure that the codes are the best representation of the services that were provided. And so for health and behavioral assessment, intervention services, those really are focused on supporting the patient in improving on their physical health conditions. And so if that isn't actually captured in the coding, we can often go back to the providers to add more information about the behavioral, physical health, more so than behavioral health. And sometimes we can go back to the payers and receive reimbursement.
Yeah, and we do the same thing when we get denials. We look at the coding again just to make sure that we got it correct the first time, and we do try and rebill anything that is possible to be rebilled. And we follow the same process that Jonique mentioned.
It's been so helpful when providing clinical services, doing the service and documenting it, to have folks like Jonique, I've experienced that, have Jonique review the documentation to make sure that the documentation matches the code selective. That support is really empowering to BHCs in primary care. Having that support lets us move forward in things that we may be nervous with too, in terms of trying new codes. Having the billing folks do a double check is really helpful.
Great, and then I think we put a link to a survey in the chat. Please, if you're hopping off in our last couple of minutes here, please complete that survey. As we've said, this is a journey, not a destination. And so all of the comments are really helpful. The other thing we heard is the chat transcript would actually be a helpful resource to people. So we'll clean that up and we'll include that in the materials that we send out, because there were some helpful tidbits thrown in there. I guess I would invite any of our panelists to share a parting thought in 30 seconds or less, and then we'll be done today.
It's worth it to go on the path of billing for these services. Insurance companies and other folks in our system need to know what BHCs are doing in primary care. We are adopting the primary care behavioral health model significantly, and we are providing tons of behavioral health services in primary care. If we don't bill for these codes, people will not know what we're doing, and that puts us at risk, and it puts our ability to provide the care in primary care at risk. So it's it can be scary both for the clinician and for the organization to move forward with billing this work, but being invisible in a system doesn't tend to promote the model. So it's worth it.
I would add, Julie, that this is a way to be seen by the payers. It truly is a way to be seen by the payers, and we have not been seen really since we've started. So yes to that. I would also say, don't be afraid to try things. We all started by experimenting. And again, very small scale, one clinician or one practice in a system. So really not being afraid to try something and, you know, and revise and learn from that. I think there's a lot of chatter in the chat about different codes, and you can't do this and you can't do that. Yes, there's a lot of rules. We've tried to kind of boil it down to what we've learned, and this is a tool we are using in our system, and the four of us put it together, and it's not it's a prototype, exactly like what we said. It's a prototype. So, you know, use it to make your own, or use it the way it is, or take some and leave the rest at the door. It's up to you, but don't be afraid to try something.
Great. All right, we're right at the hour, and I know folks have to hop off to their next thing, but thank you very much to our presenters today, and thank you to the attendees for all the thoughtful questions. We look forward to following up and potentially hosting future learning opportunities for you. Thank you.
All right, thanks.
Thanks.
Thank you.